Good morning, and welcome to our 6th virtual town hall devoted to 2020 planning activities here at Johns Hopkins University. I'm Lainie Rutkow, a professor in the Bloomberg School of Public Health and senior advisor to President Ron Daniels. I serve as one of the team members leading our 2020 planning efforts. I'm delighted to be moderating this session today with 3 of our distinguished university colleagues. Today, I'm here with Jon Links, professor in the Bloomberg School of Public Health, vice provost, and chief risk and compliance officer for the university. He's joined by Kevin Shollenberger, vice provost for student health and well-being, as well as Lauren Sauer. Lauren is an assistant professor in the School of Medicine and director of operations for the Johns Hopkins Office of Critical Event Preparedness and Response. The goal for today's session is to discuss general issues related to screening, testing, and tracing as we prepare for a return to campus. Our thinking in these areas will be captured in a set of draft guidelines describing what screening, testing, and contact tracing for COVID-19 may look like during Johns Hopkins University's return to campus. That document will be informed by many sources, including guidance from the Centers for Disease Control and Prevention, a health advisory group composed of leading subject matter experts from within the Johns Hopkins faculty, and discussion and feedback that we receive, including during this town hall today. Once shared, these guidelines should be considered in conjunction with the draft Return to Campus Guide, which contains proposed guidelines about topics such as maintaining an inclusive workplace, altered staffing and scheduling plans, significantly augmented cleaning protocols, required physical distancing, and university face coverings. The draft guidelines will not be the final word. They're intended to spark discussion, feedback, and revisions as we consider the many issues presented by the complex and diverse operation that is Johns Hopkins. As a reminder, our discussion today will focus on screening, testing, and tracing during Johns Hopkins University's Phase 1 of reopening. In our announcement for this session, we asked you to please send us questions beforehand, and we appreciate the many that we've received. Below this screen is also a box that will allow you to send in questions in real time. We will answer as many of the questions submitted by participants as we can. Like our other sessions, this town hall is being recorded, and it will be available for asynchronous viewing. We'll also work to use the questions that we've received to put together an FAQ document. Now, let's get started. I'd like to first turn to Kevin, who will give us an overview of the Johns Hopkins COVID-19 call center.
Great. Thank you, Lainie. 1 second. So in order to broadly implement response activities for returning JHU affiliates, we're working to expand the Employee COVID Call Center, which we call the ECCC, into the Johns Hopkins COVID Call Center. All Hopkins affiliates from every school with concerns about symptoms of exposure consistent with COVID-19 will be directed to utilize the JHCC as their direct link to screening and testing. Currently, all employees are strongly encouraged to call the ECCC regarding any COVID-related symptoms. Students at the 3 Baltimore schools, public health, medicine, and nursing, call University Health Services, and all other 6 schools call the Homewood Health Center. Why we're moving to have things co-located is to better coordinate and leverage our resources, and it also allows for a smoother transition between each of the steps. I just want to share briefly kind of the overview of the functions of the call center. The first is call intake, screening, and evaluation. There will be a team that will provide phone evaluation, provide advice in person if the person needs to stay at home, and if they meet the criteria set by the Johns Hopkins Infection Control, we'll order testing. And we'll talk a little bit more about testing in a moment. The second function of the call center is around results reporting, disposition, and a handoff to care management. This group will advise the patient on their results, and if they test positive, we'll advise them on next steps, as well as what to do to isolate. They will need to isolate for at least 10 days, starting from the onset of symptoms and until at least 3 consecutive days of no fever without the use of fever-reducing medication. And then the third function of the call center is around investigation, contact analysis, and notification, which I will talk about in more depth after the testing section. Thanks, Lainie.
Thanks, Kevin. Now we're going to hear from Lauren, who will provide additional context before we move into the nuances of testing and contact tracing.
Thanks, Lainie. In times of pandemic, it's understandable to want to do everything possible to protect yourself from becoming ill. And we recognize all of the work that has already gone in across the institution to keep our Johns Hopkins colleagues, faculty, staff, and students safe and healthy. Testing and contact tracing are important elements of public health strategy in conjunction with other interventions when we think about reopening the campus. We want to reiterate the importance of continuing to use face coverings in public, maintaining social distancing wherever possible, and washing your hands as frequently as possible. While wearing a mask or face covering will reduce the risk of you from spreading COVID-19 if you have it, and especially if you don't know it, social and physical distancing and frequent thorough hand washing are still the best ways to avoid getting COVID-19. In conjunction with the testing and contact tracing activities of the JHCC that you'll hear about shortly, we're considering all of the options for pre-screening. So the activities that would happen before you interact with the JHCC. There's several technology options that we're exploring right now for pre-screening of symptoms. There's a role for daily symptom attestations and daily screening. And we're working quickly to determine the best technology solutions for the Johns Hopkins community. We're also evaluating the use of on-campus temperature monitoring. There are several pros and cons that we're currently evaluating. We're looking at all the options that impact and improve our ability to protect the Johns Hopkins community. We'll make a determination based on those pros and cons and move forward with a broad strategy for pre-screening and attestation of symptoms. Thanks, Lainie.
Thanks, Lauren. I'm now going to turn to Jon, who will speak about testing.
Hi, folks. I've spoken with some of you before about testing, and I'd like to repeat some of what I've said and expand on it. I think that testing is one of the most misunderstood aspects of the response to COVID. And I think the media are not our friends in how they portray testing. So I'm going to try to demystify it a little bit. There are really 3 distinct uses for testing that have been talked about. The first and most obvious is for medical management. That's when someone who has symptoms that are consistent with COVID-19 is tested to help make a determination of whether they are in fact infected, because that guides treatment and other medical care and isolation decisions. So that medical management use is, of course, what's been with us and what will continue to be with us no matter what. The second potential use of testing is in epidemiologic surveillance. And for this use of testing, in addition to testing all those with symptoms consistent with COVID-19, we would test a random sampling of asymptomatic persons. And the goal of epidemiologic surveillance is not to understand what's happening at an individual person level, but rather to what's happening within a population, for example, our campus community. And so epidemiologic surveillance, which would involve additional testing over and above that for medical management, would give us a sense of whether our primary public health control measures, masking, distancing, and hygiene, are working effectively as we bring more and more folks back onto campus and as we progress through the phases of our plan. The third, and I think least understood use of testing, is for public health containment. And you've heard many reports in the media of some colleges and universities considering testing everyone, either upon return or on some sort of schedule that involves multiple testing of folk. And we ourselves have spoken about the possibility of such testing. Because right now, the prevalence of COVID-19 in our population is actually quite low, and because the current tests that are available are not perfectly accurate, that is, there are false positive results and false negative results. This use of testing for public health containment, where you test everyone and isolate all those who test positive and quarantine the close contacts of those who test positive, leads to a lot of unnecessary isolation and quarantine. So what are we thinking about right now? For phase 1, which officially starts on Monday with the return to research labs, we will be using testing for medical management purposes. If you have symptoms consistent with COVID-19 and you call the call center, a determination will be made during that screening phone conversation, and if appropriate, you will be referred to medical testing for COVID-19 and then follow up based on the results of that test. That's what we're doing in phase 1. We are contemplating in phase 2A adding additional testing for epidemiologic surveillance. There would be a lot of details to work out, including how big a random sample of our community would need to get tested on a daily or weekly basis in order to help inform us of the population prevalence in our community of COVID-19. Depending on how test accuracy improves, how the prevalence of COVID varies in our population, and other factors, we will make decisions down the road about any other uses of testing. Lainie, back to you.
Thanks, Jon. Kevin, now I'm going to turn to you to speak about investigation, contact analysis, and notification.
Great, thank you. Much like testing, there's been a lot in the news about contact tracing, which is really a fundamental tool used to reduce the spread of communicable diseases. And contact tracing is used for many other diseases like TB and measles. So this is not something new. And it's done by the local or state health department. So public health nurses and epidemiology staff have been doing this for years and are experts at it. Exposure investigation, or contact tracing and notification, is legally a responsibility of the local health department, so jurisdiction of the Maryland Health Department. And we are working very closely with the health department in order to avoid duplication of efforts in our contact tracing. So what does this process involve? We are currently training a team of contact tracers with oversight from the Johns Hopkins Hospital Epidemiology and Infectious Control, which is HEIC. They will do in-depth interviews with case patients who have tested positive. During those interviews, they will be asking a series of questions to get a list of persons, activities, and locations visited during the time frame of infection. And part of what we are trying to determine in those interviews is if they've had meaningful interaction or contact with someone who then may have been exposed. And we are defining meaningful contact as more than 15 minutes of exposure, less than 6 feet away. At that point, once we determine if there was meaningful contact and we have the list of people, that team will then follow up with those individuals identified that were exposed and conduct counseling and monitoring with those folks to initiate the quarantine process. In order for us to really end the chain of transmission, quarantine is very important. So anyone who has come in contact with an infected individual is asked to quarantine for 14 days from their time of exposure and to monitor their symptoms daily. This team will also work to help the student, faculty, or staff monitor those symptoms and then clear them when they are ready to come back to work or lab or the classroom. Lainie?
Thanks, Kevin. We're now going to turn to questions, both those that we've received in advance and ones that are coming in now. And I want to encourage everyone who's watching to please submit questions. We are very much looking forward to answering them. Lauren, I'm going to send this first question over to you. What is the current scientific consensus regarding how the virus is spread? And is aerosol exposure a concern or only droplets?
Thanks, Lainie. It's really important to remember that we're still learning so much about this virus and how it transmits in the population. There's been a lot of discussion on spread in the last few weeks in the literature and from the WHO and the CDC. Right now, we believe that the primary transmission route is droplets, and so we're using enhanced droplet precautions for working with the virus, working with patients, and working with the possibly exposed. There is a chance with all new emerging pathogens that guidance may change as we learn more. And so we're continuing to do studies on this, to evaluate the literature, to keep apprised of the most up-to-date information as we put new guidance out.
If I can just add a little bit to that. So we've been talking about masking, distancing, and hygiene. And we're going to always talk about masking, distancing, and hygiene. The masks or face coverings are primarily for the benefit of others because they trap what otherwise would be the introduction of droplets into the air by the person wearing the mask. The distancing works because of the focus on larger droplets that settle out of the air rapidly over short distances because of gravity. And then, of course, hygiene we know about. It prevents you from picking up the virus on your hands and then touching your face and transmitting from surfaces via your hands to your face. I do want to say that the most recent literature has also raised concerns about smaller aerosols, those emitted even from speaking and even breathing. And depending on the characteristics of a particular mask, it may or may not trap those smaller aerosols, and those smaller aerosols can stay airborne and travel over a greater distance in an enclosed space, much more than the larger droplets that we tend to focus on. Out of an abundance of caution, in addition to masking, distancing, and hygiene, we are increasing the air exchange and the filtration in all rooms on all campuses. And so we are paying attention to all of the possibilities being raised in the emerging literature and reacting accordingly.
Thanks, Lauren and Jon. Kevin, this next question is for you. What would happen to classrooms if someone in them, faculty or student, tests positive? Will everyone be quarantined, and how will they be informed?
Sure. So the first is the person who tested positive. It's important to know that they will be asked to isolate. So for the period of time that I had shared earlier, at least 10 days, and then at least 3 days when they no longer have a fever or symptoms and are no longer on fever reducing medication. When a person does test positive, we are working much like occupational health does now for employees, where the appropriate supervisor or person at that school will be notified that that person should not be returning to work or the classroom until they are cleared. The contact tracers will then determine if there was meaningful contact in that classroom or in that lab. And so part of those of you who tuned in on the academic side know that we were really looking at classroom setups where there is social distancing and 6 feet apart. So we'll really need to determine if there was that meaningful contact. So it's not necessarily an automatic that everyone in that classroom or lab would need to quarantine. That will be part of the determination during that contact tracing. We'll also then work very closely with facilities, again, depending on what comes out of that contact tracing, if any areas need to be cleaned. And those cleaning protocols were in one of the earlier documents that was released in the return back to campus.
Thanks, Kevin. Jon, this next question is for you. What metric or metrics do you find most useful to follow to determine trends in COVID and COVID cases as we think about moving to different phases?
So in case all of you don't know, Lainie and I facilitate a formal health advisory group made up of faculty from the schools of public health and medicine who advise us on just this sort of thing. They've advised us on a number of aspects of the plan. And we have created a set of metrics that fall into two categories: public health metrics and then operational metrics. And we use both sets to help inform us about whether we can move into the next phase, frankly, as we go along, whether we need to retreat back a phase, and so on. And I'll just remind you that when we introduced the original framework with phase 1, phase 2A, phase 2B, and phase 3, there was a stop sign in the diagram of that framework, which identified a number of things that would cause us to move back. So it's not just we're ever marching forward. Depending on the conditions at the time, we may unfortunately have to retreat to an earlier phase. The metrics include those that you would imagine. So we're looking at number of cases on a daily basis, Baltimore, Maryland, DC, number of hospitalizations, number of ICU admissions, number of deaths. We're going to look at Johns Hopkins health system specific metrics so we know what's happening in our own community, and those are a set of public health metrics. We're also looking at our testing capacity, our contact tracing capacity, our face coverings on hand, our isolation and quarantine status amongst our affiliates, and so on, as additional operational metrics. And we will be tracking all of these.
Thanks, Jon. This next question, Kevin and Jon, you may want to tag team on this one. For someone who falls within CDC guidelines as being among the most vulnerable to COVID, can they be confident that all students in their class of 15 will have been tested before the course begins?
I'll take that. The answer is no. And in fact, if they were never symptomatic and are currently asymptomatic, it is very likely they will not have been tested. As I said earlier, the testing of asymptomatics is much more likely, in fact, to lead to a falsely positive test than a truly positive test. And so the routine mass testing of everyone as a screening maneuver right now, we don't think is a good idea. Obviously, we are monitoring very closely the combination of improvements in test accuracy and in the actual prevalence in the population. As tests become more and more accurate and as the prevalence in the population grows, this notion of testing everyone becomes a more logical thing to do. But given what we know right now about the accuracy of the tests and the prevalence in the population, we don't think it's a good idea. We do think that the control measures in hand masking, distancing, hygiene, ventilation of the rooms is how we're controlling the spread of the disease. For those who are in a vulnerable group as defined by the CDC, there will be a formal accommodations process through the Office of Institutional Equity that will deal with such folk. For those who do not fall within one of those vulnerable groups, but feel their life situation has particular risks associated with it, there will be a companion adjustment process handled by Human Resources and your school.
Thanks, Jon. We're getting several questions related to the aerosols that came up earlier in this discussion. So, Jon, I'm going to turn to you for these. Is 6 feet sufficient in an enclosed space given the information that that was discussed earlier in this town hall about aerosols?
So the smaller aerosols is speculative, whereas the large droplets is a known. And for the large droplets, 6 feet is adequate. Indeed, in Europe, it's 1 meter, so it's 3 feet, not 6 feet. We are increasing room ventilation out of an abundance of caution, not because there's strong evidence that these smaller aerosols are a meaningful risk. Increasing the air ventilation is something we can do, and it doesn't impact people in a negative way. We can run the ventilation system 24 hours a day, so it consumes a bit more electricity. We can change the filtration. Most of the buildings already have very high efficiency filtration in them, in the air handling systems. But so it's one of those, it can't hurt, we're gonna do it. People often ask me about surface contamination. How come you guys keep talking about hygiene, all the washing your hands, washing the surfaces? Everything's getting cleaned at least once a day, high contact surfaces multiple times a day. That again is out of an abundance of caution. The primary route of transmission is large respiratory droplets during coughing and sneezing. Everybody agrees on that. The other stuff, if it's not interfering, let's do it.
Thanks, Jon. And one more question related to aerosols. What is the potential role for plexiglass barriers in an office or classroom setting?
So the plexiglass barriers are really there for the large stuff. And so if you think about what's happened in grocery stores, what's happened in banks, what's happened in post offices, and so on, that's for the coughing and sneezing. The masks are also for the coughing and sneezing. If you have a mask and if you have a 6-foot distance, a plexiglass barrier is really not necessary. Where they've been erected have been in cases where either the distancing isn't guaranteed to be 6 feet. It isn't, for example, in a grocery store, or a bank, or a post office, and where, at least until recently, you couldn't guarantee that everyone was wearing a mask. So we're looking at plexiglass barriers, but they likely would only be in special circumstances.
Thanks, Jon. Kevin, question for you. Will testing be offered in Washington, D.C. for JHU students, faculty?
Yes, so DC students, we're still encouraging them to call the JHCCC to get their phone triage and evaluate. and then from there can assist in ordering tests. We're currently in conversations with our affiliate Hopkins hospitals in DC to provide that testing. So more to come on that, but yes, we are looking to provide testing in DC.
Thanks, Kevin. Jon, when you were talking about testing and decisions related to testing, you mentioned down the road. Could you speak a little more about what down the road means?
So we are literally on a daily basis monitoring a variety of important metrics, conditions, the literature, etc. I remember when Stephen Ganji and I did the first of these town halls, and at the time acknowledged the tremendous amount of uncertainty surrounding both COVID and our plans. I do think our plans have evolved over the weeks since that first town hall, and there's more specificity, but honestly, there's still a tremendous amount of uncertainty in our planning because there's a tremendous amount of uncertainty around COVID, what's going to happen over the summer, in the fall, what's going to happen with new tests, and so on. So I said down the road because I'm acknowledging being vague. With respect to phase 1, though, we have no plans to change our testing approach for phase 1. So until we enter phase 2A, we will be using PCR-based testing for medical management, and then all of the associated activities that Kevin described.
Thanks, Jon. Another question for you. Can you speak about antibody testing? Is this something that the university plans to offer, and could it be used for epidemiological purposes?
So there's really two broad types of tests. Testing for the presence of the virus itself, and testing for antibodies that the host person's body has produced in response to the presence of the virus. And for the virus, when we talk about PCR testing, we're talking about nucleic acid-based testing, so the nucleic acid of the virus. There are also antigens or proteins associated with the virus that we could conceivably test for. We're following that testing technology closely. With respect to the antibody testing, that is still an incredibly emerging technology. And there's two big sets of uncertainties with it. The first is the sensitivity and specificity of the test itself. And the second is how you actually even interpret the test if you detect antibodies, because the presence of antibodies is not the same thing as congratulations, you have immunity. And in fact, depending on the analytic sensitivity of that antibody assay, you could detect a low level of antibodies that would have no clinical or operational meaning. And to tell the person, okay, you have antibodies, would be very misleading. So we're very much following the antibody story, but antibody testing is right now not part of our plan. That, of course, is subject to change.
Thanks, Jon. Lauren, question for you. Why is cleanup so important when CDC says that touching surfaces has not been a major spread of COVID-19? A major source of spread of COVID-19.
So cleaning surfaces is really important to remove the droplets that we've talked about earlier in this call. And while it may not be a major source or the major source of spread, it is still an important element in our sort of infection prevention control toolkit. So if the droplets are there and they're relatively fresh or relatively new or on a surface that can support their stability for a bit of time, cleaning and disinfecting of that surface will be another step in the ability to control the way they infect other people. So if you have a room, for example, where there has been recent use and there is a person who created droplets that had infectious particles in them and they're on the surface, that disinfection process will protect other people from possibly getting them on their hands, touching their eyes or touching their mouth or nose, and thus the virus spread. So while it may not be the primary driver of controlling spread, as much as that social distancing piece and that good hand hygiene and the masking that we've been recommending, it is still a really, really important part of our public health and infection prevention toolkit.
Thanks, Lauren. Jon, for you, what is the plan if a new wave or outbreak of COVID-19 occurs during the semester? Are contingency plans being worked out in advance?
Absolutely. So this notion of which we hope we don't have to invoke of going backwards as well as forwards in the phasing is an explicit part of the plan. And in the same way, we rapidly made a decision to send folk off campus in March. And we really hoped this wouldn't be the case in the fall, but if in fact we have a phase 2A measured return to campus and in the middle of the semester, things take a turn for the worse, we are not going to just doggedly continue, and we will go back into a lower density operating posture. And it will look familiar to everyone. And because we're tracking the metrics the way we are, we think we'll be in a position to rapidly make such a determination, which, as I say, I hope we never have to make.
Thanks, Jon. A few more questions related to the phases. In phase 1, what would be an acceptable % of positive tests to move to the next phase?
So decisions to move from phase 1 to phase 2A will not be based on one metric or two metrics or three metrics. It'll be based on a constellation of factors, including the metrics I identified a few minutes ago, the set of public health metrics, the set of more operational metrics, as well as forecasting the scenarios, the waves, what we think will happen, and so on. So there is no one magic number that we're going to look at and say yes or no go or no go. Since you ask about what's called testing positivity, let me just comment on this metric for a moment. So I have said that the prevalence of COVID-19 is actually very low in the population. It's around 1% roughly at any given point in time. And that means, in theory, if you had a perfect test, which we don't, and you were testing everyone, then 1% of those you tested would have a positive test result. In today's world, we're not testing everyone. We're preferentially testing those with symptoms that are consistent with COVID-19, and we don't have a perfect test. We use test positivity to tell us something about the availability of testing. Early on, there were states where every single test was positive. If every single test is positive, you're not testing enough people because you're only testing the sickest of the sick. And the greater your testing capacity and the more people you refer to testing, the lower the % of all tests that are positive. The threshold has been a moving target, but is currently around 5%. You want the percent of tests that are positive to be 5% or less.
Thanks, Jon. Kevin, 2 questions for you. Where can folks access the contact info for the JHCCC, and how long does it take to get a testing result?
Great question. So we are still in the process of operationalizing the JHCCC. So employees should still call the ECCC, which will actually be the same number. And East Baltimore students call University Health Services, and all other students call Homewood Health Services. You can get those numbers if you go to the Hub website and you click on the banner that says COVID-19, and there's a little icon that says if you're feeling sick or having symptoms, and it lists all the numbers. As soon as those things get merged, we will make sure to update all of our communication. And then the second question, I'm sorry, remind me, was?
How long does it take to get results once you have a test done?
Yeah, right now it's been, this is, I want to quantify, if they get tested through Hopkins, it's been about 24 hours that we've been getting those test results. If people decide that they want to be tested through their primary care, who may send it out to a lab, those test results we've noticed can take up to 2 to 3 days, which is one of the reasons we really encourage people to use our service.
Thanks, Kevin. Okay, several questions related to contact tracing. Kevin, I'm going to send this one to you, and Jon might want to jump in as well. How will folks who are in a room with someone who tests positive for COVID-19 be made aware of that?
So they will be made aware, again, if it's determined that they had meaningful contact with that person in the classroom or in the lab. So again, we're defining that as at least 15 minutes of contact, less than 6 feet. And I should have said earlier, that's even if they're wearing a mask. We're still seeing that as meaningful exposure, because we know that wearing cloth masks is different than kind of a more medical mask. If we're not sure, then we may then look at, do we need to kind of communicate with the entire class or lab if we're uncertain about the contact that they may have been exposed. But that really is going to come out through the contact tracing and interview process.
So let me just add a little bit to that. So first of all, I want to emphatically state that, quote, being in the same room as someone who is COVID positive is not meaningful contact necessarily. That is not meaningful exposure by itself. In phase 1, because of the 400 square foot per person requirement, and in phase 2A, because of what turns out to be a 7.5 foot separation of students from each other and everyone from the instructor, there actually ought to never be meaningful contact in a lab or in a classroom. I can't state that strongly enough. When Kevin talks about the process to determine who is a close contact, I want to highlight what's called case investigation. So when a person gets tested and they test positive, they get a call back informing them that their test result was positive, and of course, telling them what they need to do to take care of themselves. So the clinical management all gets discussed. Then in addition, the person is interviewed about their close contacts. And it is through that interviewing process that anyone who was a close contact gets identified. What that means is that if someone in a lab or in a classroom was tested positive, the most likely outcome is that no one else in the lab or in the classroom will be notified because none of them should have qualified as a close contact.
Thanks, Jon. Question for you. Like I said, we have a few related to contact tracing now. Why are we not talking about contact tracing apps, and what, if any, are the plans for these?
On this town hall, we haven't spoken about contact tracing apps, but in our planning, we are totally talking about contact tracing apps, as well as apps for a variety of additional purposes, health screenings, monitoring of density in buildings, and so on. I just described what happens in case investigation in order to really understand who is a close contact in a meaningful way. And because of that process, right now, given the accuracy of the digital contact tracing apps, we're in much more of a monitoring mode than a quickly rushing to fall in love with them mode. We think that what's called manual contact tracing right now is the way to go, and that is our plan for the immediate future. Some of you may know that the School of Public Health produced a Coursera course to train contact tracers, and literally hundreds of thousands of people, including some of our own, have taken that training. And we are building our own cadre of contact tracers that will do the manual contact tracing. And the notion is to have the size of that cadre be sufficient to keep up with the emerging demands of contact tracing as more and more folk return to campus over the coming months. We're hopeful that digital contact tracing may be a supplement in some ways to that. And as I say, we're watching that technology as it emerges. And I should also say we're partnering with the Maryland Department of Health on that to do so.
Thanks, Jon. And you anticipated something that we've had several questions about, so I just want to ask you to state it one more time. Is JHU, are we hiring our own contact tracers or using state and county health department tracers?
We are doing our own contact tracing, just like we're doing our own testing. Where there are still details to work out is, will we be expected by the city or state to contact trace contacts who are not Johns Hopkins affiliates? And will our tracing of our affiliates who are close contacts of our own test positive affiliates, will our contact tracing be deemed sufficient by the city and state? We think it will be. But those are legal details as much as operational details that have to get worked out. But it is absolutely our plan that we would like to test our own and contact trace our own, and that's the way we're proceeding.
Thanks, Jon. Kevin, are there costs associated with testing for COVID-19?
Yeah, it's a great question. And so insurance companies have been directed that there should not be copays or charges for testing. So there should be there is no cost to the person being tested.
Thanks, Kevin. And additional question for you. Can a non-JHU affiliate of who's a spouse or a household member of someone who is affiliated with the university who has symptoms get tested at Hopkins?
They can. They will need to get a test ordered through their primary physician. And if they get that test ordered, the testing site at Hopkins is also for the larger community. It is not for JHU only folks.
But they would not go through the JHCCC. They would not go through the call center that students and employees would use. They would be treated as a member of the community who is seeking healthcare at Johns Hopkins.
Correct. Thank you, John.
Thank you both. Lauren, this question is a follow-up to something that you mentioned earlier in the town hall about use of face coverings. What is being done to keep an eye on that to ensure that folks are being compliant?
Yeah, so maybe I'll mention this briefly and then hand it over to John. We are working to ensure that we have non-hospital face coverings, so available to the community, so that we have a supply and to ensure that people have face coverings available to them when they go onto campus. And we have a plan for having safety monitors ensure that people are using them appropriately while on campus and on campus facilities. John, anything to add to that?
Yeah, so the program is formally a safety ambassador program. This is about all of us building a strong, safe, and healthy community together. And so we will be roaming the hallways to make sure that face coverings are in use and distancing is being observed. Thanks,
Lauren and John. John, earlier in your remarks, you mentioned an approximately 1% prevalence of COVID. Can you clarify if that 1%, if you were speaking globally, nationally, locally?
So the 1%, the notion of prevalence, I'm going to launch into a Epi 1 lecture if I'm not careful, but the notion of prevalence, there's not just one meaning to prevalence. And so if you think about it, at any point in time, there's a fraction of the population that is actively experiencing COVID. And that's the 1% I'm referring to. But there are also members of the population who have had COVID historically. And that you can think of that as a cumulative prevalence that might be greater, but it's not active virus present. And in the context of testing for the virus, it's active virus present that we're concerned with. And so that it's called a point prevalence is what we're interested in. And that's the 1% I'm referring to. Honestly, it's probably less than 1%, but I use 1% just as a rounded off value.
Thanks, John. And going back to testing, when folks are tested at Hopkins, what type of tests will be used, and is there a saliva test?
Okay, so testing, you know, I've said that testing is this totally confused topic. And when people say testing, oh, I went to this site to get tested. They went to the site to have a sample collected. They have no idea where that sample travels to actually get run as a molecular assay. And so we are separately looking at all the variety of different samples and all of the variety of different molecular assays. So I've said that for right now, it's RT-PCR as the molecular assay. So that's looking at the nucleic acid. For right now, it's nasal pharyngeal swabs, the really long Q-tip that looks horrible when you see it on TV being stuck up someone's nose. We obviously would like to go away from that. Everyone would. So what about the more anterior portions of the nose? What about swabbing your cheek? What about saliva? We are investigating all of those. While all are promising in certain studies we're doing and our colleagues around the world are doing, there are complications. I'll just give you an example. Saliva testing looks like it's most accurate if you get the sample right when you wake up. So before you've done anything with your mouth, basically, like get a drink of water, brush your teeth, gargle with mouthwash. And so were we to go to saliva testing, it would likely be to distribute the little sample vials and have folk capture the saliva first thing in the morning. And if it's like, wait a minute, but my symptoms came on later in the day and I love brushing my teeth, then it's like, okay, maybe it's not saliva for you then. So I'm just trying to illustrate the complexities. Every question you folks are asking is a fantastic question. And I feel like none of them have a straightforward answer. And that's thanks to COVID itself.
Thanks, Jon. One more for you. What should employees do, or who should they contact if they see folks who are not complying with social distancing or face covering use while on campus?
So we are shortly launching a communication campaign that will clearly direct people to different sources of reporting, whatever they feel most comfortable with. It could be a supervisor. It could be the compliance hotline that you can use for absolutely any concern or complaint. I run that hotline. It is anonymous if you want it to be anonymous, like even I don't know who you are, anonymous. Or there is a separate health, safety, and environment reporting line as well. So we're going to try to create a variety of opportunities for reporting.
Thanks, Jon. Kevin, question for you. Will there be a sample collection site for testing that's based at Homewood?
So for phase one, right now our testing site will continue to be at East Baltimore, and we have arranged for transportation options for folks who aren't in East Baltimore if they don't have their own transportation. But for phase 2A, return to campus, part of the plan is to have a testing site on the Homewood campus.
Thanks very much, Kevin. Well, we are down to our last minute. Let me ask one quick final question and then we'll close it out. We've actually gotten this question several times. Kevin, I'm going to start with you, and Jon may want to jump in, which is for those that are taking the contact tracing Coursera course, is there a role for them to play within the university's contact tracing effort?
There is. I love that question, actually. We have already started redeploying staff who take in the course to serve as contact tracers and be part of the JHCCC team. We anticipate that we'll need to ramp up that team. I'll need to check on this after this, but HR has an internal listing. And so if folks are interested in serving in that role, they should respond to that HR listing. I will say that the JHCCC, we're looking that is open from 7 a.m. to 7 p.m., 7 days a week. So we definitely need folks who can fill those shifts.
Thanks, Kevin. I want to close by thanking all of you for participating in today's town hall. And while I know that we weren't able to answer every question, I hope that this session provided further clarity about the extensive planning to facilitate a safe and efficient return to campus. This session was recorded, and an archive will be provided on the web, as has been done for the other town halls. We will soon share draft guidelines describing screening, testing, and contact tracing. As a reminder, this document will be informed by multiple sources, including guidance from the Centers for Disease Control and Prevention, a health advisory group composed of leading subject matter experts from within the Johns Hopkins faculty, and discussion and feedback we receive, including from this town hall today. As we continue in our planning, we anticipate holding additional sessions, and we will notify you when those are scheduled. Until then, please remember to continue adhering to good public health measures. Wash your hands often, avoid close contact, and maintain social distancing, and continue to wear a face covering when in public. Keep safe, and we look forward to seeing you at our next town hall.